all the bad times I feel myself. I'm off the tip, watching. And John Lewis has been with us for several years. And as we've mentioned, what's good for your heart is good for your brain. So he gives us just 10 minutes of general things that you can do. Do them at your own risk. Make sure you have a stable, steady chair. And I think he mentioned something about getting a towel and some other things. So with that said, I am going to turn it over to John. Give me 1 second, John. I'm going to try to highlight your video so that everyone can see you full screen. All right, have at it, John.
All right, before we get started, we're going to warm up, and I'm going to show you how to use a towel to stretch and also elongate those muscles and also tone that upper body. So let's get started. As I grab this towel, I'm gonna pull. I'm contracting the muscles, pull. Let's go angle, pull. Other side, pull. And there we go. Here we go. Arms up straight. Let's go. Pull. Good job. Here we go. Let's stretch. Pull. And pull. Other leg. Pull. Rest. Let's get that waistline. Arms straight. And the towel is keeping you level to make sure you don't slump over. Let's go. Waistline. Pull. Come on. There we go. We getting that waistline. We're working that lower back. There we go. We get a nice stretch, and we're working on those details. Good job. All right. Before we start this one, if you want to stand up, grab your chair and hold on. And if you don't, sit down and do the same motion. So if you can get up, let's get up and let's get started. In my leg, ain't stop. Let's go. Oh no, let's go. Won't stop. Won't stop. I can feel it. Let's go. In my head, I want it back. Come back. All right. All right. I can feel it. What? In my heart, I want to sing. Go to bed. Go to bed. Go to bed. Switch leg. Bad boy. I want to be on the base. On the chest. On my chest. Number one. Let's go. I'm bad. I'm coming. You cool. Bad boy. All right. Bad boy. Come on. Either way. All right. Come on. Good job. Hey, we're getting that cardio up. Everywhere we go. Here we go.
Hardcore, motivated, dedicated, stimulated, percolated, all the way, every day, 1 mile, no sweat, 2 miles, better yet, 3 miles, all the way, 4 miles, every day, sounding good, feeling good, all to be, Hollywood, we're the best,
now the best.
Test. Number one.
Above
the rest.
Yeah.
Yeah. Oh yeah.
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 Oh yeah. Come on.
Motivated. Dedicated.
Stimulated.
Percolated.
Percolate.
All the way.
All the way.
Every day.
Come on.
1 mile.
Come on.
No sweat.
No sweat.
2 miles.
2 miles.
Better yet.
Better yet.
3 miles.
3 miles.
All the way.
All the way.
4 miles.
Good job.
Every day.
Woo! We getting that cardio up because cardio is life. Here we go. One more.
Everywhere we go, got the feeling in my leg, can't stop, oh no, don't stop, got the feeling in my head,
Get that circulation on. Straighten them out.
alright, got the feeling in my heart, I wanna sing,
Motivate.
dedicated,
Dedicated.
working tough,
Come on.
bad boy, wanna be served away, on my chest, number one, I detest, I'm me,
I'm me.
I'm bad,
I'm bad.
I'm
I'm
home,
home.
cool, bad boy,
Bad boy.
alright, bad boy,
Bad boy.
lead the way, alright.
All right. Good job. We're working that upper body. I'm going to finish with this cardio now.
Hardcore. Motivated. Dedicated. Stimulated. Percolated. All the way. Every day. 1 mile. No sweat. 2 miles. Better yet.
We getting those hamstrings right now.
All the way. 4 miles. Every day. Sounding good. Feeling good. Ought to be. Hollywood. We're the best.
Let's twin.
Number one. Above the rest. Yeah.
Yeah.
Oh yeah.
Oh, yeah.
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 Oh yeah.
Oh, yeah.
Hardcore. Motivated. Dedicated. Stimulated. Percolated. All the way. Every day. 1 mile. No sweat. 2 miles. Better yet. 3 miles.
Can we do one leg?
4 miles. Every day. Sounding good. Feeling good. All to be. Hollywood. We're the best. Fly test. Number one. Above the rest. Yeah.
Triple.
Oh yeah.
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 Oh yeah.
Oh, yeah. Good job.
Right now, I just need you to get real loose. Get comfortable. Grab your loved ones,
Hey,
or grab your love partner. If you're by yourself, no worries.
I'm going to get this waistline.
To me, a little two-step, then cowboy boots.
Come on.
Sweetheart, and spin out when
Come on.
we go down and get push. Back to the left now and dip. What it don't throw down.
There we go. We get that waistline. We get these hips.
Up to the left now. To the right. Now take your left hand and put it on your side. Don't roll your shoulders. You slip and slide.
Come on.
This next part's my
Watch this now. Watch this.
This time,
Oh.
I'm a little two-step, then cowboy boots. Sweetheart, and spin out when you hold down and get push.
What?
Back to the left now and dip. With it on throw down, take a sip, put it out, lean back, put your head.
Come on.
This something you can do. Slide to the left, slide to the right. Now cool down, have a good time. Slide to the left, slide to the right. Do the butterfly, have a good time around.
Oh, let's do the butterfly. Here we go. Let's get these hips. Loosen out. Come on. Oh.
I'm a little two-step, then cowboy boots. Sweetheart, and spin out when you hold down and get push. Back to the left.
Great job. Great job. We got that circulation going. Hey, I enjoy life, and you should enjoy life too. And I've been your drill sergeant, and see you later. Bye.
Wow. Okay, are you dedicated? Are you motivated? Hello. Okay, so very quickly, the rundown for today is Dr. Hepburn is going to address caregiver conflict, and then Dr. Parker is going to come in and address vascular disease and cognition, followed by Dr. Brewster, who's going to address sleep management. And then we'll close out with our topic about COVID-19 and antibodies. So take notes and be sure to if you have a question or an issue, just comment in the chat, okay? And so while I am getting Dr. Hepburn ready, Dr. Hepburn, if you want to, and he has to go, guys, so he's double booked, and that's why we switched some things around today. So I have to, go ahead, I'm sorry.
I'm just recovering from the workout.
Oh, absolutely, wasn't that great?
Yeah, as always. He's amazing. That's not my slides.
Yep. Give me just a sec. And if you want to talk about and introduce your topic.
Sure. Well, once again, hello, everybody. It's great we have so many people, I think, who return to these, and that's gratifying. And we're pleased to get your questions because it helps us come up with topics that you find meaningful, and that's what we want to be able to address. So one of the questions that was raised a while ago and then came up last week is around conflict that occurs in families providing care for someone living with the dementing illness, and how to kind of handle that. And so I have 10 minutes and don't have all the answers ever. But let's see what we can do. So go to the next slide, please. The thing, next slide. There we go. So practical starting points. In trying to deal with family conflict, don't let the perfect be the enemy of the good. If you can work something out, even though it's ragged around the edges, it's better than nothing and it's going to help. The second principle is that some hills aren't worth dying for. There are going to be some long-standing conflicts, and trying to get into them and sort them through is going to take maybe a lot more energy than it's worth. And so choose your battles, and continue to believe in miracles, but also understand that a lot of times they don't happen. So with that as a preface, let's go to the next slide. I think we talk in the programs we give about types of family caregiving, and we always make the point that families are what you design and what you define as a family. And so we identify 5 possible types. I have to tell you, I have snuck into my office. I'm right on Clifton Avenue, and there's ambulances and fire engines, so sorry for the background noise. The kind of perfect world is a collaborative caregiving arrangement. Everybody's on the same page. It's a sort of Sound of Music caregiving, right? Everybody's marching up the hill singing. It happens. I've seen it happen. I've seen multiple members of families who meet monthly. They have planning meetings. They decide which one of the granddaughters is going to write the grandmother a hello, thank you, and sort of greeting card every other week, and who's going to do the taxes and who's going to visit and all that. It happens, and when it happens, it's great. A lot of times there's a kind of I think the normal state is solitary caregiving. One person's it, maybe they're distant people, but mostly she or he feels alone. Quite a bit of time, there are observed caregiving situations. That's where somebody's living and taking care of the person, and there are people watching and giving their opinions. I think you're treating dad like a baby, or you're not taking good enough care of yourself. And so the caregiver is getting this feedback and feeling sort of whipsawed, watched and whipsawed, but not helped. Sometimes there are tag team arrangements. 3 months here, 3 months there, 3 months somewhere else. And not infrequently, there are uneasy alliances. These are situations where there are real disagreements and maybe people working at cross purposes. I've had a lot of cases where, you know, one evil sibling is trying to steal money from mom while the other two siblings are trying to protect her. It's the real world and it happens. So one thing to do to start with is just acknowledge where are you in all of this. Next. I'm going to go through the next 3 slides pretty quickly, and it's a series of steps for you to map out what you got with your own arrangement, kind of think about it, and then arrive at a ideal state, what you'd like. So first step, put you and your person in the middle of a blank piece of paper, and then begin to name people and organizations who are part of your world. Make them bigger as they're important to you, and make them further away or nearer as they seem to be providing more or less care. So in this case, here's a nephew down here who's far away but sort of playing a big role. Up here is a family doctor, and no disrespect to Dr. Parker here, because she's the exception. But that guy is pretty small. And the faith community is over here, but also small. So kind of get a picture of your geography, your caregiving geography or village. Next. And then begin to draw some arrows. The next slide. And the arrows should be robust in terms of the degree of linkage, and they should be pointing either in one direction, like the daughter to you, where the daughter's getting a lot of help, or in another direction, where the nephew is making a lot of demands, or even bimodal or bidirectional, where you're getting something from your faith community, but the faith community keeps asking you for something in return, not just donations, but time and effort and whatnot. And still you got some people out here who you're not getting anything from. Your family doctor this is like a dotted line. You get a little bit, but not that much. The old friends, same deal. So take that into consideration and then think, you know, given where I am, what would I like to see happen? So next slide. And here, what you're really saying in this kind of arrangement is, I'm going to pay a whole lot less time and effort to that nephew. I'm going to reach out to brother and say, you know, I need your help. So you're going to have to be the one to reach out, because he's been out there being silent, not doing anything. But you got to ask for it. The faith community, you might want to say, you know, right now I need from you and I can't give back. I've given plenty, but I need that. The old friends, they're not coming around anymore, so I'm not spending any more energy on them. The neighbors have been good, and I'm going to ask for more. I'm also going to see that there are formal support services, and I haven't been asking for that. I'm going to ask for that help. And I need more from my doctor, so I'm going to ask. And God bless her, I'm going to keep the daughter and the brother perking along just the way they are. So that's the 3 steps, and I recommend those that you create in your own mind a map of what you would like to have happen. Now, the next and last slide. Ideally, you'd like to see movement. If you've assessed your family as being one of these situations, you're a solitary caregiver, maybe you'd like to move more to a collaborative arrangement. Once you see what your geography looks like, you can begin to think, I'm going to ask so-and-so for more help. If it's an observed thing, if your daughter on the East Coast and your son on the West Coast is just kind of hassling you, intervene with that and say, look, I'm not perfect, but I need some help. Let's work on this more together. Let's be more collaborative. If you got a tag team thing going, maybe there are ways to sort of create more of a unified plan. Frankly, if you're involved in an uneasy caregiving alliance, I'd break it off. If you can boot that scheming, no good, name the sibling, get rid of him. Because he's not helping you and he's not helping the person who's being cared for. You got to be a little assertive. You got to be a little bit sort of cold-blooded, and but it's for you, and it's for the person you're caring for, and it's going to improve the quality of your life and that person's life as well. 6 slides. That's all I got.
Wow, thank you, Dr. Hepburn. Knowing that, you know, women are typically the primary caregivers, what would you say if you are doing solitary caregiving? I mean, families are not always blood. You mentioned the church. What other resources do you think could be at our disposal in this caregiving component?
I think both friends and fictive kin are really important to persons who are in the solitary caregiving situation. I think it's been so interesting to me in this time of social isolation, how often I have written emails to people I haven't been in touch with for a while, just to sort of say, how are you? I think the solitary caregiver has a network out there to which she, likely, or he has not reached out. And so just reaching out and reestablishing a line of communication so that there's a tangible felt sense that I am in a community. But beyond that, there will be people that communication can then increase a bit. They're never going to come in and be caregiving helpers, but they can be listeners to you. They can remove some of that sense of isolation you have, and they can be pressure valves for you. So I would really look at that map and include those distant, haven't been in touch with them for maybe a couple of years, but now might be the time to tap back into that.
Yeah. Absolutely. And I like your thought of mapping out the caregiver and it being bi-directional. So for those of you who perhaps are just joining, if we have your email address, we will send out a PDF of the slides as well as the recording. So be sure to check your email. The documents will be embedded in the body of the email. Thank you, Dr. Hepburn. I don't know if you have time to quickly see it.
Dr. Parker just posted a really interesting chat comment that I wonder if you could come on and talk about it. So, sort of managing unruly family members with rules.
Okay. Dr. Parker, are you unmuted?
No.
Okay.
Sure. I'm in the process of typing a response to that. That's a really good question. Okay. So one of the things that's important is you have to give unruly family members rules. And so who gives the rules? Okay. The durable power of attorney for healthcare, the durable power of attorney for finance. If you don't have those documents in place to say who can do what as it relates to money and as it relates to healthcare, you don't really have a leg to stand on. You know, that's how you manage unruly relatives. You can call a family meeting with a case manager or somebody else and objectively state all the things that need to be done. But you need to give family members who have an opinion about something an opportunity to contribute to the solution. If they're going to just moan and groan and create stress, as Dr. Hepburn says, you need to jettison them. You need to get rid of them. Give them their buy papers. Get them to let them leave. Okay. I'm being nice. But I think the most important thing that family members can do, and for all of you here, whether you're a caregiver or not, you need to sort out your own life. You know, who's going to take care of your financial matters if you are unable to do so? Who's going to manage your healthcare issues if you are not able to do so? And have you written those sorts of things down? So a lot of family confusion can be prevented if we write stuff down, put it in writing, and make sure that both our family doctors, our bankers know who to deal with. That's how you cut down on some of the confusion. So the first thing that I would say is let's get some rules. And part of the rules of managing vulnerable elders or vulnerable individuals is making sure who's in charge. So you have to have a legal document on that order. So designating and making sure that you have in place a durable power of attorney for healthcare who determines healthcare issues consistent with what the patient or the family member affected would be wanting. That's one person. Durable power of attorney for finance. Somebody that person, the caregiving recipient, trusts to manage their financial affairs, pay their bills, determine financial matters. Those two people are the most important people. Everybody else is just noise in the universe. So get your family on board, make sure that you have these documents in place, make sure that you've had a family conversation or discussion about these different issues. But most importantly, if you are an older adult and you are of sound mind right this moment, tomorrow you might have a stroke and you may not be. Make sure that you have got these documents in place so that your care is consistent with what you would want it to be in the event that you are unable to make these decisions for yourself.
Okay, so take that from her because she's the real doctor.
All right.
Thanks,
Any closing
Monica.
remarks, Dr. Hepburn, before we transition to our vascular
what she
dementia?
said, you know.
All
Okay.
right.
Thanks.
Okay. So next up, Dr. Parker is going to present on vascular dementia and cognition. So last week, Dr. Parker, if you want to do a short recap while I pull up your slides.
Okay, so last week we talked about the different brain functions that deficits in 2 or more brain functions constitute a diagnosis of dementia. So what were those brain functions? Well, we all know about memory loss, but in neurology, and when we start talking about dementing disorders, Alzheimer's is but one, there are other types of dementia. Okay, there's the vascular, which has to do with strokes and hypertension and blood pressure. There is Parkinson's dementia. There is dementia that's associated with chronic alcoholism. There is dementia that's associated with HIV/AIDS infections. And then there are people who are affected by a combination of factors. Maybe you have Parkinson's disease, but you also have hypertension. All of that stuff kind of affects your brain. So if we remember what the different brain functions were, there's executive function, there's perceptual motor function, there's learning and memory, there's social inhibition, all those sorts of things. Go back to our lecture last week, our webinar last week, and pick up some of those things. So to pick up today, thank you, Dr. Hepburn, first of all, for his identifying family struggles as a primary care doctor. I can tell you because I've been blessed out in the hospital, on the floor in the hospital. I've been blessed out in the doctor's examination room. And because I'm supposed to be nice, I try to count to 10 every time I have to deal with people like that. But as a family, you can create and avoid problems by putting the right documents in place. We had our elder care attorney on a couple of weeks ago. Get your documents in place, and that eliminates a whole lot of confusion. So to get to the topic that I'm to talk about today, I have a slide up that says that the Lancet Commission for Dementia Prevention, Intervention, and Care, as of July 2017, none of this stuff has changed. 30% of all dementia is preventable. I'm going to say that again. 30% of all dementia is preventable. Vascular dementia is largely something that is preventable. What are some of the things that you can do to prevent vascular dementia? Well, there's a list of things on there that talk about what we can do to prevent dementia, but I'm going to focus today on the second bullet, which is managing hypertension. Number 2, which has to do with preventing obesity. 3, smoking cessation, which puts you at risk for strokes. 3, treating diabetes. Okay, so those are vascular risk factors for brain dysfunction. Next slide, please. What is brain dysfunction? What are the different types of dementia? Okay, this slide, just as a recap for what we've been talking about, dementia is a many-splendored thing. There are several different types of dementia. The most commonly diagnosed dementia is Alzheimer's at 60%. There's a mixed vascular and Alzheimer's disease and Lewy body at 14%. Vascular, pure vascular, which has to do with hypertension, diabetes, which is what we're going to talk about today, is about 17 to 20% of all documented dementias. Parkinson's disease, frontotemporal disease, chronic traumatic encephalopathy, HIV, and chronic alcoholism kind of round out the circle. But note, the most commonly diagnosed is Alzheimer's, but as research progresses and we learn more about brain dysfunction, we find that more people have not so much just pure Alzheimer's, but combinations of things that involve some of the pathologies of the other different dementias. Next. So what is brain dysfunction? Okay, I have a column here, a panel that shows protective factors for brain and risk factors for brain dysfunction. Concentrate on the things in red. Chronic disease management. If you have a diagnosis of high blood pressure, if you have a diagnosis of type 2 diabetes, if you have a diagnosis of hypercholesterolemia or elevated cholesterol, those are what we call vascular risk factors for certainly vascular disease. Those are the things that predispose you toward developing a stroke. Okay, everybody understands what a stroke is, but a stroke, 60% of all people who have had a stroke, whether it's silent or not, will develop cognitive deficits and changes. Over there on the right-hand side of the slide, you have risk factors. The ones in red, hypertension, diabetes, obesity, and cardiovascular disease. If you have any of these diagnoses, these are things that put you at risk for developing some type of dementia or cognitive dysfunction, something that will result in your ultimate inability to take care of yourself. Next. What are vascular risk factors? Okay, when we start talking about vascular dementia, it generally follows from things like stroke and cardiovascular disease. That is what CVD is, cardiovascular disease. What are some of these entities? Atrial fibrillation, heart failure, hypertension, high cholesterol, and diabetes. Now, why is diabetes up there? That doesn't have anything to do with my heart. Well, diabetes accelerates or speeds up the process of atherosclerosis or hardening of the arteries, or the process by which blood vessels no longer supply blood to the brain. Keep going. So what are strokes and what is dementia? Loss of blood flow to the brain causes the death of the neurons or ischemic brain damage. You might have heard that. Ischemic means loss of blood, okay? So if you're not getting enough blood flow to your brain, you're not getting enough energy or enough electricity up there to make the brain work properly. And if the brain is not getting enough electricity or enough juice to make it work properly, it just dies, okay? Some people have what we call silent strokes, okay? When we think of strokes, we generally think of motor strokes where people have a flaccid face or a limp face or a part of their body that's not working. So they walk and drag their feet, okay? But most people don't have those kinds of strokes. They have silent strokes where they have loss of blood flow to the brain, and wherever it is they've had that blood flow loss, they're going to have an infarct that shows up on an MRI. This infarct on an MRI is what we call white matter hyperintensity or white matter disease. People say, oh, I don't have anything on my MRI. I just got white matter disease. Well, that white matter disease means that you have brain cells or neuron cells in that area that aren't functioning. They're not working, okay? So depending upon where it is, that's going to be effective. If the frontal part of your brain has had a little bit of a stroke, you're going to have problems with your emotions and recognizing things. If you have a stroke in the back part of your brain, in your motor cortex and your cerebellum, you're going to have difficulty with the way that you move and you mobilize, okay? Different parts of the brain that lose blood flow no longer perform the function that they're supposed to. Keep going. Let's keep going with this brain blood flow thing. Okay, so what does high blood pressure do? High blood pressure, particularly high blood pressure that's not controlled, is a significant risk factor for vascular disease. So what does high blood pressure do? It disrupts the lining of the blood vessels. All of us know what blood vessels are, but keep in mind, if your brain is going to work well, if your heart's going to work well, it's got to get enough blood flow. And if you don't get enough blood flow because your blood vessels are choked off with atherosclerosis, which means that the opening to get into your getting brain from point A to point B, blood to point A to point B, goes from a big circle to a little itty bitty minuscule circle, that means you have impaired blood flow. So impaired blood flow to the brain, cerebrum, causes a problem with how your brain cells function. People who have problems with blood flow to the brain will have increased A beta, which is the protein that's associated with Alzheimer's. They will have more of an accumulation of this protein that's associated again with Alzheimer's, but it's also associated with heart disease. And they'll have increased inflammation. So when we think of anything that ends in itis is inflammation. So if you have arthritis, you have inflammation of the joints. If you have vasculitis, you have inflammation of the blood vessels. And so what hypertension does is it creates a certain amount of inflammation in the blood vessels, such that blood vessels do not do what they're supposed to do, which is transport oxygenated blood from an end to an end organ. Keep going. Next slide, please. ApoE4. It's indicated, it's shown that people who have an ApoE4 who are heterozygous, means that they have two genes that indicate that they have ApoE4, are more likely to have Alzheimer's. But we also know that people who have ApoE4 genetics are at increased risk for cerebrovascular leakiness, or blood vessels that don't work, or little hemorrhages or bleeding, such that the blood vessels that supply the brain are not working. Again, getting back to my definition, if you have poor blood flow to the brain, you end up with bleeds, you end up with neurons in your brain that don't work. And on an MRI, you show these white matter intensities. And making things really simplistic, that basically means that you've had little micro strokes and poor blood flow to those areas of the brain. We're not exactly sure what the mechanism of action is between how the ApoE4 genetics affects the vascular function, but that's a research thing. Okay, keep going. So what does heart failure have to do with blood pressure and brains? Okay, well, your heart is the pump that gets blood to the rest of your end organs, whether it's your brain, your heart, your kidneys, your legs. If you don't get enough blood flow there, whatever that end organ is, it's not going to work well. So if you've been a smoker and you don't have good blood vessels in your legs, you're probably going to have pain in your legs, or claudication, or peripheral vascular disease. Well, if you have a poor pump function, if your heart's not pumping enough blood anywhere, especially to your heart, you're going to start to have problems with the way your brain works, okay? So lack of blood flow to the brain results in brain shrinkage. Lack of blood flow to the brain can be caused by those little mini strokes. Those little mini strokes are things that cause blood not to flow to an end organ, usually caused by little itty bitty clots, emboli, blood clots. So brain shrinkage we see on an MRI. In Alzheimer's, we see shrinkage of the hippocampus and different parts of the brain. If you have high blood pressure, we want you to treat your high blood pressure to keep your heart from overworking such that it no longer pumps effectively and you develop heart failure. How do you treat heart failure? You manage the high blood pressure. Keep going. So antihypertensive medicines or high blood pressure medicines help keep your heart and your brain functioning, okay? Heart failure itself, once somebody has developed heart failure, it may be an independent risk factor for Alzheimer's, but it's certainly a risk factor for developing problems with what we call vascular dementia. If you remember last week, we talked about the different brain functions. Vascular dementia is associated with memory loss, but it's also associated with executive function, which is your ability to plan, your ability to learn and manage things like driving, recipes, etc. Okay? Atrial fibrillation. There are a lot of people who have this particular condition. Keep in mind, this is another cardiovascular condition. What's important about atrial fibrillation is it makes it more likely that you're going to develop little clots that cause the stoppage or impede the blood flow to an organ, whether it is your brain, in which case you're having those little mini strokes and microinfarcts that develop, your kidney, or your lower extremities. This manifests itself, these little silent strokes manifest itself on a radiologic image on an MRI as a lacunar infarct. These lacunar infarcts represent those white matter lesions that we see on MRI. These white matter infarcts are associated with what we call vascular dementia and also with Alzheimer's disease. They can be found in combination. Keep going. Type 2 diabetes. Well, I don't have any of that. I just have diabetes. Well, elevated blood sugar levels are related to vascular disease and the development of heart disease and everything else because it accelerates that atherosclerotic process. Insulin resistance, which is usually what's happening when you have type 2 diabetes, causes increased amyloid development and decreased amyloid clearance, which is one of the pathologic features of Alzheimer's disease. It also causes problems with the blood vessels such that blood flow to the brain is not what it needs to be. And again, if the blood doesn't get enough blood flow, it atrophies or it shrinks. Nerve cells die, which is what we call neurotoxicity, like low oxygen to the brain causes neurotoxicity, and increased peripheral inflammation, increases problems with blood vessels around your body. So you have more of that inflammation, more itises. Keep going. White matter hyperintensities, again, I think I've explained this enough. This is basically the evidence that you have problems with the blood vessels that supply your brain with oxygen such that it works correctly. Okay, this is the radiologic finding when we do a neurologic workup that we're looking at. Well, somebody's confused. Are they confused because they have Alzheimer's, which is consistent with hippocampal degeneration, or are they confused because they've had lots of strokes and their brain's not working well? Okay, white matter hyperintensities are indicative of problems with blood vessels that aren't working well that are associated with brain deterioration. Keep going. So in summary, I'd like you to appreciate that vascular dementia is a consequence of having cardiovascular disease. Cardiovascular disease is inclusive of hypertension, heart failure, atrial fibrillation. All of those things cause low blood brain perfusion or low blood flow to the brain, which we call hypoperfusion. This shows up on a radiologic image or brain MRI, and it shows where you have problems with blood flow to the brain. These things are not reversible. There's a question that popped up that I can actually see. These things are not reversible. So once you have impaired blood flow to the brain and the end organ or the brain cells or the cells affected die, is there any recovery? No, they don't come back. So what we hope that you'll do is prevent or control those risk factors. If you are overweight, if you have diabetes, if you have hypertension, we want you to control those things to make sure that you don't develop the vascular complications. Extensive, poorly managed hypertension results, quite frankly, in heart failure. How do we get from heart failure to atrial fibrillation? Well, remember, the heart is a pump and it has to efficiently lubed up, lubed up, lubed up. Well, if it's not doing lubed up, and pumping like it's supposed to, some blood pools. And when blood pools, what does it do? It clots. And when blood clots, little clots are available when the heart does pump to be pushed off somewhere and block something. So heart failure, atrial fibrillation causes the development of little microclots that generally obstruct or impede the blood flow of blood to the brain. That's
All
it.
right. Okay. Thank you, Dr. Parker. That was exceptional. I think you did a great summary about managing all of our chronic illnesses, staying active. I saw several comments pop up in the chat. We are going to transition now to our discussion around sleep because we want to be mindful of your time. So Dr. Glenna Brewster is going to share with us how we can manage our insomnia during this time. I know my sleep has been interrupted and disrupted, so I'm excited to hear about this topic.
All right, thank you, Cornelia. So there are normal age-related changes that we have with sleep and when we observe it in older adults, because we see that older adults tend to go to bed and wake up earlier than younger adults. And what we often notice is that they often have difficulty with initiating, meaning they have difficulty getting to sleep and staying asleep. And because we're thinking about this with persons living with dementia and us as caregivers, what happens is that persons who live with dementia may actually experience some day and night sleep pattern reversals. So they might sleep a lot during the day, then at night they're awake. Or they might have frequent awakenings at night, or they might have increases in daytime sleepiness and napping. And when this happens, what happens is that caregivers will then have multiple nightly awakenings because they're waking up to help the person who's living with the disease, or they tend to go to bed after the person goes to bed, so they have shorter sleep duration, or they tend to take a longer time to fall asleep because many times they might be worried or concerned about the person living with dementia. Or they have inconsistent sleep-wake times, meaning they go to bed at 8 one night, the next night they go to bed at 10, or they wake up at 6 or 5 or 8, so it's very inconsistent how they go to bed and sleep. As a result of this, many tend to develop insomnia. So here we see the insomnia as insomnia, the definition is difficulty initiating, so difficulty getting to sleep, difficulty staying asleep, or waking up very early in the morning with the inability to return to sleep even though you have adequate sleep opportunity, or you have ideal environmental factors. And it's often accompanied by daytime clinical distress or functional impairment. So that means when you don't sleep well, therefore you wake up the next day and you find yourself being even more irritable, or you can't think well, you can't focus, you just feel tired. And 30% of adults or so suffer from insomnia, but with caregivers up to 66% experience insomnia, and up to 71% of persons living with memory impairment actually experience insomnia. And even with the COVID going on now, we have a lot of people who might start experiencing some symptoms of insomnia. So some people might be sleeping more, while some people might be sleeping a lot less. Next slide, please. Okay. So it's not, all is not lost. There are ways that we can actually manage insomnia. So one of the first things that we often talk about is cognitive behavioral therapy. And that is actually, it has many parts, so it's multi-component, as you can see, and it involves stimulus control therapy, sleep restriction or consolidation, therapy, relaxation training, cognitive restructuring, and sleep hygiene education. And the goal really of this cognitive behavioral multi-component intervention is to replace unhelpful thoughts and sleep habits and to reduce arousal associated with sleep. Another thing that we often talk about or use is mindfulness-based stress reduction techniques. So those techniques they aim to reduce reactions to stress by teaching awareness. So you have to be purposefully aware of what is going on and accepting of the present state. And it includes techniques such as breathing, body scan, or hatha yoga. And in cases like this, when you're using mindfulness-based stress reduction techniques, you can also integrate relaxation training in that. And relaxation includes deep breathing, progressive muscle relaxation, or guided imagery. And quite a few of these examples are found on YouTube or online videos. So there are some times where I actually have gone on YouTube and type in relaxation, and many options that you have to do a guided imagery or a deep breathing exercise or progressive muscle relaxation. And we know online there are breathing techniques and also some different yoga things that you can do. The other thing for management of insomnia is actually bright light therapy. And with that, the goal of bright light therapy is to help to strengthen circadian rhythm. And circadian rhythms have to do with our 24-hour rhythms of our body. So when we wake up and when we go to sleep. And bright light therapy helps to do that so that we can establish a healthy sleep-wake cycle. Healthcare professionals recommend white light sources with a bluish tint, and it can that provides at least 1,000 lux at the eye during the daytime hours. So one of the things I would say would be, anytime you are having any sleep difficulty, and we talked about this earlier, is to speak to your healthcare provider about it. I think because we don't put as much of an emphasis on sleep, when we have sleep disturbances, we tend to accept it as is. instead of speaking to our providers or healthcare providers about it. And then the final thing that I have on this slide is exercise. And exercise is very protective in terms of, we talked about hypertension and heart disease earlier, so protecting us against that. But it also helps with improving our sleep and helping us to protect us, as it were, from developing insomnia. So the recommend is to exercise at least 150 minutes weekly to help with that. Next slide. And sleep hygiene is one of the things that is included in cognitive behavioral therapy. So sleep hygiene actually is personal and environmental activities that we can do that can influence sleep. And some of these sleep hygiene techniques include maintaining a sleep schedule, including on weekends. So that means that you are especially waking up at the same time each day. So if you, during the week, you work and you get up at 7 o'clock each day, even on weekends, still continue to awake at 7 a.m. in the morning. And when you awake, get out of bed. Don't be awake and stay in your bed for an hour or 2 hours reading or doing other things in bed. So maintaining a sleep schedule. Another thing is to practice a relaxing bedtime ritual. So whatever that is for you, whether it is listening to a relaxing cassette or tape or music, listening to that, doing progressive muscle relaxation, something that helps you to put your body or tell your body it's time to go to bed, a warm bath, warm tea or milk, something like that. Just have a relaxing bedtime ritual. Sleep on a comfortable mattress or pillow. Turn off electronics before going to bed. And we encourage that you would, turn off your electronics, because electronics tend to have light, and light promotes us actually staying awake and not falling asleep. So when light is released, then our body isn't going to release melatonin, which is what is usually released to tell our body it's time to go to bed. So if you can, an hour before bed, turning off electronics. Exercise daily. Limit caffeine and alcohol intake prior to bed. Caffeine tends to keep us awake, so it will prevent us from falling asleep. Some people say caffeine doesn't have an effect on them, but for the average person, it tends to keep them alert and awake. And alcohol persons tend to say help you fall asleep, but while it might help you fall asleep, the sleep that you actually get throughout the night is actually lighter than you would get on a night without alcohol. And finally, evaluate the bedroom for ideal temperature, sound, and lighting. So you want your bedroom cool, quiet, and dark. The darker it is, the better for sleep that you would find. So those are just some things that I wanted to talk about, to provide that you can start to put into practice from this afternoon if you would like to. And I think I saw somebody ask the question earlier about melatonin. And melatonin is actually a hormone that your body produces naturally to help with sleep, and it doesn't work immediately. So a lot of times whenever we're telling people about melatonin, we're encouraging them to take it to 30 to 60 minutes before bed, before actually wanting to go to sleep. But if you're going to take melatonin, also remember that you need to speak to your healthcare provider about it. So you shouldn't start taking a medication or provide or give your loved one a medication, regardless to whether it's over the counter or not, without speaking to your healthcare provider, because many of these can actually interact with some other medications that you might actually be taking. So that's what I would say about melatonin.
Okay. Thank you, Dr. Brewster. Natalie, did you see any more? We have time for one more before we transition to our closing presentation about COVID-19.
I think a good question that's kind of come up is that there hasn't been a discussion about sleep medications. They weren't on the list. And so how, that impacts.
Somebody, I think, asked earlier about sleep medications. So for older adults, especially, or people living with Alzheimer's disease or any type of dementia, we would say that is contraindicated, but once more, it is based on what your doctor recommends. A lot of times, the medications that are prescribed for sleep for persons living with, or even older adults, if you're 65 and older, they tend to have side effects like dizziness, increased cognitive impairment, increased risk for falls. And because of that, and they're anticholinergic. So anticholinergic means that, there's a drying effect. So because of that, then we would not recommend them for persons over 65 or persons who already have memory impairment. That is why we tend to want to focus on behavioral things that you can do, that you can actually manage, that might have less of an impact physiologically on you. I think Dr. Parker also had mentioned that.
To add on to what Dr. Brewster is saying, what those cholinergic effects are, we talked about drying things. One of the things that's problematic for older adults is chronic constipation. Chronic constipation can be alleviated by increasing hydration and movement. Sleeping medicines like Benadryl, people like to take Tylenol PM or Benadryl PM. This is something that causes more dry mouth, that dries up secretions, whether it's your mouth, your sinuses, or your gastrointestinal tract, such that you're more likely to have constipation. If you are a man and you have an enlarged prostate, the symptoms that go along with having an enlarged prostate are likely to be exacerbated or made worse because you are taking these sleep aids, which cause the bladder outlet obstruction, which is what it is, to be worse. So in general, if you are under the age of 65, I'll say under the age of 50, you may consider a prescribed sleep aid like Lunesta or Restoril or something for a short term, not on a chronic basis. As Dr. Brewster has said, if you're having difficulty for you to sleep, you need to consult with a sleep specialist to help understand why you are having difficulty sleeping. A lot of people suffer from something called sleep apnea. And what sleep apnea is it means that when you sleep, you don't get enough air. And so to make sure that your body gets some air, you snore and your body wakes itself up so that you can take a breath. So people go, okay? That's because you're not breathing. So your body wakes itself up so that you can take a breath so that you can breathe. Sleep apnea is a very toxic problem. It contributes to the symptoms that are associated with dementia. And if you are overweight or you have a big, thick tongue, you might need to see a sleep specialist who can kind of help do a sleep study to determine why you're not sleeping all the way through the night. So this is why we don't want you to take sleep meds. Thank you, Dr. Brewster. And with that, we'll move on to the next title. I'm your presenter for the COVID-19 antibodies, and I'm a substitute for Crystal Johnson, who is our nurse. You've been listening to the news and you've been hearing a whole lot about, I need to get my COVID-19 test, but now you're hearing about COVID-19 antibodies. What does that mean? Well, generally, when you get an infection of any kind, let's take something that I think people are going to be very familiar with, measles, okay? If you've been given an immunization against measles, and most of us in this age group, and I'm in this age group too, we had measles when we were little, and we developed antibodies when we had that infection so that we don't get measles again. With the Corona-19 virus, the idea is that, oh, if I have the Corona-19 virus, I'm developing some antibodies to make sure that I don't get it again. Well, not so fast. If you don't have what we call neutralizing antibodies, those are the antibodies that keep you from getting infected again, you probably are going to get COVID-19 again. That's why people are working on a vaccine, much like when we get the flu vaccine. It may not be to the flu for this year, but it helps us develop some antibodies that help us fight the viruses so that we don't get so sick that we have to be hospitalized. Okay, just because you have antibodies doesn't mean that you're not going to get this again. Perfect example, the common cold is a coronavirus. And we get common colds over and over and over again. Why? Because it's a different coronavirus over and over again. If it was the same coronavirus, chances are we might have developed some neutralizing antibodies. But chances are we've got a different coronavirus and we're going to get another common cold. So to make it simple, coronavirus antibodies form 1 to 3 weeks after you've been infected. And if you've generated enough of the neutralizing antibodies, it may protect you against getting that type of Corona-19 virus again, okay? It doesn't mean that you're immune if you don't have if you don't have the neutralizing antibodies, you're not immune and you're likely to get another infection. Next slide, please. So it's like, why do we get this test? Who needs to get this test? You know, different studies are ongoing now to help us understand which and who's making antibodies and who is not. And those people who are making neutralizing antibodies are being tested such that we can develop a vaccine from those people who have those neutralizing antibodies. So until then, we have to practice continued social distancing, wearing a face mask to keep ourselves from getting infected. Should I take public transportation or a carpool? Well, that's up to you. You need to see what kinds of precautions and safety precautions or health precautions have been put in place by that provider. This pertains to Lyft, this pertains to Uber. If you're going to go from point A to point B in your family vehicle, you're going from point A to point B in your family vehicle. But if you're going into a commercial vehicle, can we talk about how they're sanitizing after people ride in the vehicle? Are they using not hand sanitizer, Clorox wipes to wipe down the vehicle once you exit the vehicle? So if you are going to be traveling in a car with people that you don't normally live with and spend every day with, you need to wear a mask while you're in carpool. You maintain social distancing. I can't talk about this enough. The simple stuff is still the important stuff. Even though we're free to walk around, we still need to wear a mask simply to protect ourselves if we're asymptomatic from transmitting the virus to somebody who is likely going to get it. But we also have to clean surfaces. You know, if you're going to come in contact with bodily fluids, if you're going to wipe somebody's derriere, if you're going to wipe somebody's nose, food, things like that, you're going to want to make sure that you have on gloves and you protect yourself against contamination with all the things that we're learning about. If you're a dentist, if you're a dental hygienist, if you're a doctor and you're going to be working in somebody's nose or mouth where you're likely to be infected with respiratory droplets, I can't just wear a cloth face mask. I need to wear an N95 mask. I need to put up a visual screen to keep the droplets that may be coming from your mouth or your nose from affecting me, and vice versa. Next. What precautions should I take at work or dining in a restaurant? Same things that we've been talking about. Social distancing, 6 feet of distance between you and somebody else. If you are going to eat, of course you can't eat with a mask on, but you should have thought about that before you decided to go out to eat, okay? When you finish eating, you put your mask back on. If I decide to eat, and I recommend contacting the restaurant, if you want to eat out, call the restaurant that you're going to, see what they're putting in place to help you with your safety. And if you have to have all of these if you have to have certain things in place and you don't feel comfortable, maybe you don't need to dine out. Maybe you don't need to dine in the dining room. But all restaurants now are posting information about what they're doing to keep you safe and what to do to keep things clean. Social distancing, face masks. Keep going. Always remember the number one thing to prevent infection for this coronavirus is to wash your hands frequently, stop touching your face, your eyes, your mouth, your nose, maintaining that 6 foot distancing between you and the next person. And if you're just going out in public, no, you shouldn't wear a face mask to run, but if I've stopped running and I'm going to go enter the QT or the Publix, I need to put a face mask on, okay? If you're going to come in contact with hard surfaces that are likely contaminated, you want to wipe those things with the Clorox wipes or make sure that they're sanitized. You don't necessarily have to wear gloves, but if you're caring for someone, and those of us in healthcare understand this, if you're coming in contact with bodily fluids, yes, we're going to be wearing gloves. We may be wearing a protective jumpsuit. You've seen there's a television story about Naomi Campbell traveling in a head-to-toe like jumper, like a little cocoon. She made a cocoon. If she wants to do that, that's fine. But the take-home point there is she's taking the risk of traveling in public, and she's doing what she thinks she needs to do to protect herself from getting the virus. So keep that in mind. You're protecting yourself, but you're also protecting the public.
Absolutely. Okay, so that concludes our formal presentation. There are so many questions in the chat, so we will just try to address a few of those. What about gloves? Dr. Brewster, Dr. Parker, I know Crystal Johnson addressed this
Okay.
a few weeks ago.
What about gloves? Excuse me. Again, if you're going to be handling things that are likely contaminated, you'll probably want to wear gloves. The same precaution applies. If I've got gloves on to push the grocery cart because I want to make sure that nothing gets on my hands, if I use those same glove covered hands to wipe my face, I haven't helped myself. So yes, you wear gloves when you're going to come in contact with likely contaminated surfaces or things that have been contaminated with respiratory droplets. You wash your hands before you put the gloves on, after you take the gloves off, all that sort of thing. Look at the CDC for their recommendations about how to wear gloves, how to sanitize masks and things like that. I saw that in the queue. How do you sanitize an N95 mask? There are things at the cdc.gov website that help you do that.
Okay.
Please discuss the difference between quarantine and isolation as it relates to COVID-19. Also, the number of days should be quarantined or in isolation. What this basically means is you're not available to the general public. So most of us, since whenever the official order went down, I know that in my house, we've been quarantined since about March 15th. That means that we have not gone out in public. We've been in our own home. We haven't allowed people to come into our home. That's what quarantine, that's what isolation means. You keep yourself separated from other people such that both you and the other people you may come in contact with are not infected with whatever you may or may not have. Okay, so why 14 days? That's what the CDC recommends. I don't know why, but I would say that if you were likely in a room with somebody who had COVID-19 active infection, within 2 weeks, you would have symptomatology that might be worsened. And so if your symptoms haven't worsened in a 14-day period of time, chances are your condition is not going to deteriorate. You're not going to require hospitalization. Any idea when it'd be possible to get a PET scan? A PET scan for what? I would say that if you are involved in research or any other healthcare entity and you need to use X-ray services of a hospital or something like that, they do that on a case-by-case basis. If it's urgently important that you have a PET scan or an MRI, you will get one, and they will do things that protect you and protect the providers who are giving you the PET scan. I would talk to my primary care doctor about when he or she will allow in-person visits, but here in the Department of Neurology, we are on telemedicine visits unless specified otherwise from now through the end of the month and certainly the first part of June. Should residents of a senior living facility be tested? No, they should be protected. If they're going to go out and about, if they have clinical symptoms that indicate that they're infected or sick, i.e. they have a fever, they have a cough, or they have a physical condition that is deteriorating, that person needs to get to a medical provider for the proper evaluation, and the proper diagnostic tests need to be ordered and implemented. I can't speak about other things, but I would say pay attention to what Governor Kemp has said for the state of Georgia. If you are a vulnerable adult or person who is medically vulnerable, that is anybody 65 years of age, anybody who is immunocompromised, you are to remain sheltered in place, which means you are not to go out in public. You people in public are not supposed to come and visit you through June 12th. After that, you have to measure it. And even at June 12th, does that mean that you go out willy-nilly? You can just walk out free-spirited, like what does Jim say, the free-range elderly? No, you can't do that. You have to go out properly covered. You have to wear your face mask and do what's appropriate. Use common sense. I know it's not common anymore, but use common sense.
Okay, well, in closing, we want to thank everyone for tuning in. We will be back after Memorial Day. We will be resuming Our Tuesday talks will continue every Tuesday. That has been the recommendation of Dr. Law to keep going, and as long as you guys attend, we will continue to provide this educational opportunity. Another opportunity, Dr. Parker, if you want to talk about the collaboration that we will be hosting tomorrow with DeKalb County via Zoom.
Yes. In salute to Honor Older Americans Month, the Lou Walker Center of DeKalb County is having a webinar. We are kind of doing a redo of a webinar we did last month in April. It is what older adults during this pandemic can do to certainly support themselves and help gird against mental health kinds of breakdowns. It's kind of like, what can you do during this period of time? So on May 20th, Wednesday, that's tomorrow at 1 o'clock, we're having another webinar in partnership with the Lou Walker Senior Center and the DeKalb County, Georgia Community Services Program. We're having another webinar and we'd love for you to take place. You can call 678-215-1961 to register. You can also look us up on our Alzheimer's.emory.edu website. I have a podcast called My Parents Are Now My Kids that you can access as well. But please, again, look at the Alzheimer's.emory.edu website for all the things that we have to offer. All of our webinars to date have been posted online. So we look forward to seeing you tomorrow and next Tuesday if you have the time.
All right. Thank you. We'll see you tomorrow or next week. Goodbye.